You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes, and you can also follow us on Twitter at ASAM.org and Facebook. Now, let's go beyond the abstract.
Welcome to Addiction Medicine Beyond the Abstract. I'm your host, Dr. Sean McNeil, and today we're joined by Dr. Ekaterina Pivovarova. She's an associate professor in the Department of Family Medicine and Community Health at the University of Massachusetts Chan Medical School. Her article, entitled Collaborating with Jails to Provide Community-Based Medication for Opioid Use Disorder, Qualitative Perspectives from MOUD Treatment Providers, is available in the January-February issue of the Journal of Addiction Medicine. So welcome to the podcast. You had a very interesting article which kind of introduced some topics that were a little bit new to me. So I wanted to jump in and talk about some of the things that stood out. Firstly, you mentioned that in Massachusetts, there is a mandate to provide care for those with opioid use disorders who are in jail. And you talked about this creating a ripple effect. Jails are also often required to do reentry planning in Massachusetts. And I was hoping that you could discuss how this all fits together and also how this ripple effect looks from a clinician's point of view.
Yeah, absolutely. So over the last couple of years, we've really seen what could be described as a sea change in terms of what is happening in the jails and prisons, really behind the wall around provision of medications for opioid use disorder. And Massachusetts has been leading the way in that, as opposed to some of the other states that voluntarily sort of chose to go that path, and another that may be supported through internal initiatives. Here we had a legislative mandate that came out in 2018 that said all of these pilot sites, which originally started with 7 pilot sites, it was actually, to be technical, it was 5 pilot sites and 2 signed on voluntarily to be part of this legislative mandate to provide all forms of medications for opioid use disorder for incarcerated individuals. And so we went from providing some of this medication, very little percent of the time, to at least in theory, providing this medication to all individuals that needed this medication within these pilot jails. And so the mandate really went into effect in 2019, meaning there was some time for the jails to prepare for this. But really, within a year or two of that, what we saw was that all jails, ultimately in Massachusetts, all of our county jails, ultimately ended up either voluntarily through their own initiative or through some sort of settlement with the Department of Justice, moving forward in also offering medications for opioid use disorder for all individuals that are incarcerated and met criteria. And I should clarify that it is not all incarcerated, but all individuals that were receiving medications for opioid use disorder in the community and were then being incarcerated. And so the difference there, of course, is that some of the jails might have had individuals that were coming in and may have been in need of medications for opioid use disorder, but not necessarily receiving those in the community or not receiving those consistently in the community, and then once getting incarcerated, did not meet the criteria of continuing the medication. Some of the jails decided that they wanted to, in fact, initiate individuals, and that was sort of a smaller proportion. And those individuals, those jails, essentially started saying that anyone who meets criteria for substance use disorder, for specifically opioid use disorder, is going to receive this medication if they want to. And so we saw this happening in Massachusetts, one from starting from that legislative mandate to expanding to these other jails, essentially covering the entire state. And at the same time, we actually saw very similar things happening in our state prisons, where the prisons started with a couple of them being part of the legislative mandate and then expanding out to all of the facilities being able to provide. There may be one or two exceptions that may be facilities. At this point, I'd have to double check, but nearly all of the facilities, correctional facilities in Massachusetts now offer this medication. And this was, aside from this being something that was clinically very important to do, it actually made things a little bit easier because when you have both the jails and the prisons providing the medications, it makes it easier to transfer. So some of the individuals might have been in jails for a brief period of time, or they might have been there pre-trial and then ultimately being incarcerated in a prison after they have received a sentence, and that way they were able to receive medications both while they were incarcerated in a short-term facility, in other words, jail, and also upon transfer to a prison where they were serving their time.
That's a great overview. And, this all speaks to what you referred to as interagency collaborations. So clinicians working with the criminal-legal partners and getting patients this kind of treatment. So I guess my next question is about this partnership. And specifically, are there any challenges or barriers to clinicians who are practicing within the forensic system or within the criminal-legal system that you could kind of outline for us?
Yes, great question. So we have been studying this implementation of medications for opioid use disorder for sort of the past 5 years, and the focus, understandably was on the facilities themselves. But what we also did in this study, this was the Massachusetts JCOIN study that was co-led by MPIs Liz Evans and Pete Friedman, was that we wanted to speak with the community providers that were going to be working with those jails. And so part of the mandate was to make sure that not only was the person receiving medications in the community, but also that there was a reentry plan that involved medications, continuing medications once they were out in the community. And this meant that whoever was doing reentry planning in the jail had to connect with the community provider, figure out a way to maybe transfer whether medical records or medical information about the services that the person was getting, and set up an appointment for them so that way as soon as they were released they can follow up. And so community providers were inherently involved in this from the very beginning, even when we don't consider their involvement directly in providing medications while incarcerated. And so these community providers sort of were in some ways in a novel place because they may have been working with jails previously, and some of our interviews sort of indicated that this wasn't necessarily novel to them, but they had never worked with these jails in such a systematic and consistent way. And so what this study really focuses on is what was that experience like for those community providers, and how did they develop collaborative relationships with the jails in order to make sure that they can then serve the patients that were coming in there. And it wasn't necessarily standard for them to be working with these jails, like I said. So there's sort of a number of things that help to support these relationships, and that's really what we talk about here in our paper. And I'm happy to sort of talk about some of those things.
Okay. Well, I know a lot of clinicians aren't very familiar with the legal system, and I know that you mentioned on a state-by-state basis Some of these programs are perhaps more robust based on which state you're in. But you also mentioned that it would be nice if federal programs also had standardized reentry services. So do you think that it's attainable to get a universal reentry system in place?
Yeah, that's a great question. I think certainly at the federal level and outside of Massachusetts, it is, this idea that community providers are going to have to work with jails and prisons in supporting reentry. I think that's very clearly where this is all headed. Whether there's ever going to be one consistent, reentry plan and a particular way of doing this, I think that's probably not going to be the case. But as we see more and more jails and prisons provide these medications inside, it's going to be very critical to ensure that community providers are ready to accept all of the individuals that are going to be coming back to the community, and that they're able to engage in the type of relationship that with these jails and prisons that is going to best serve the patients. And what we often hear, and outside of this paper and some of the other work we've done, is that community providers are hesitant to work with criminal legal partners. There is concern that these partners might harm their patients. So, for instance, in working with the courts or probation, they worry that if they provide too much information or if they engage in sort of a truly collaborative relationship, it will mean that the patient is incarcerated or can't receive a certain type of treatment, or even potentially are unwilling to directly engage with these partners because of philosophical differences and beliefs about the differences in how these two systems see treatment of substance use disorders. And in some cases, that's certainly the case, that there are going to be differences in how criminal legal partners think about addiction. But in other cases, I think there are going to be quite a few similarities in that, especially I think this goal of making sure that the patients receive the treatment that they need, treatment that is most effective and that is going to reduce overdose. I suspect that's going to be found many more places than might initially appear. And, I think the other part of this is that there is a great opportunity for community providers to serve as educators to some of the jails, prisons, and really other criminal legal partners in explaining the why these medications are crucial, why they're going to keep individuals alive, and why this transition from behind the wall to the community is the most critical time period when we want to ensure that we get this transfer done right. So the clinicians are probably very familiar with the notion that the most critical, the sort of most likely time for an overdose is for individuals recently leaving, so within 2 months, within 2 weeks, or depending on what data you look at, but really immediately after they are released from some sort of a carceral setting. And so this is the time that clinicians and community partners can say, we want to make sure we get this right. It's not that the onus should be completely on the clinical providers, the community providers, but, in some cases, that might have to be the case. But I suspect that in other situations, the jails and prisons are going to be more than happy to partner with community providers in some ways because they see this as making it easier for them to complete their work, which is to do some sort of reentry planning. And this idea of reentry planning in general is really present in all correctional facilities. The degree to which it is done is probably going to vary based on resources and staffing availabilities, but there is some form of reentry planning really in all correctional settings. And so having community partners is going to make that easier for people who are doing this work on the inside.
All right. And for clinicians that want to take initiative and get more involved in this space, do they go directly to forensic facilities? You mentioned that there are collaborative groups or perhaps local task forces that exist in some areas. So what do you think is the easiest way to get involved for a clinician or maybe an entire department that is interested in providing services in this type of setting?
Yeah. So another great and difficult question. I think the first place to start would be to recognize that there is actual benefit to collaborating with these agencies and saying we will put concerted effort into these collaborations. We might be needing to spend some staff time on sort of developing these relationships, but ultimately we believe that as an agency, this is going to benefit our patients because we will ensure that this transition happens in a way that we can ensure that access to treatment. So in terms of what are some options available? So many communities are going to have task forces that specifically look at opioid overdose deaths, or they might be centered around various other topics where the jails and the prisons are going to be part of that. So local departments of public health might be a place that sort of such collaborations or these collaboratives are available and might be helpful. But then there's also the sort of fairly direct way, which is, approaching the jail itself and trying to speak to the reentry coordinators there and saying, hey, we provide these services. You may not even be aware of all of the services that we offer. And we would like to talk to you about how we can support individuals transitioning to the community. As I say, it might feel unnatural to kind of start this initially, but if you think about it, this really benefits all parties in that this will provide some support for the jail who might not necessarily know who the partners are, what those partners do in the community, where they're located, a way to contact the community partners. And most importantly, it will help to ensure that the patients who are returning back to the community can know exactly where they need to go upon their release, whether it's to receive methadone as soon as they're released, or to make sure that they have a continued script for their for Suboxone or similar medications. And then there's this sort of, in getting to know the jail itself, one option that we recommend is really saying, I as a community member would like to understand what jails and prisons in my community look like. Can I take a tour of this facility? And in my experience, the jails and prisons are actually really willing to do that because they want to show to the community the work that they are doing. They want the community members to understand maybe types of services that are available on the inside. And oftentimes what I found is when we brought various community partners to criminal legal agencies, whether it be sort of carceral settings or courts or other types of criminal legal agencies, is that the agencies say, hey, we actually need your help not just with this issue, but can you also potentially help us with this? We're looking to provide this type of service, but we just don't have the capacity to do it. Can we partner with you? And so that's, in some ways, sort of this cold calling approach of getting to know the carceral agencies themselves, being able to understand what's happening. And then, of course, there are sort of ways to be able to provide services on the inside that some community agencies might have the capacity for. So if this is a large community provider, jails might need provision of medications for opioid use disorder in the jail space itself, and they might be willing to partner with your particular organization, or at least sort of get some feedback about what types of services are needed. One of the things that we often talk about that community partners may not necessarily see is that there is huge fragmentation of services that may happen within the carceral setting. So even though it might be seen as this one place where all services might be provided by one group, it's actually not the case. Oftentimes within a particular jail, prison, whatever sort of the setting might be, might be many different medical providers, medication providers, clinical providers. Really, the services inside may not be as cohesive as one would expect. And so that means when the community partners are trying to communicate with the jail or trying to receive maybe medical records or information about dosage or whatever it might be, it truly might be a bit of a maze in trying to get to the right person. So really just going in with the expectation that, even though it seems like it should be a single place where you get all of the information, that is not necessarily the case. So what community partners have that the jails and prisons do not is that they have clinical knowledge and expertise and might be able to offer trainings to individuals, to staff on the inside about the sort of what these medications are, the benefit of these medications. And so just like, in our community settings, we often need training hours, and we may, go to different conferences or whatever it might be to wherever we go or whichever way we receive learning about new topics. Community providers can do this for staff in carceral settings. So they can come in and say, hey, we offer, we would be happy to partner with you. And also, if you need any training on medications for opioid use disorder or on, what are the reentry needs of individuals receiving these services in the community, we would be happy to present to you, to your staff. These are things that jails may not have the money for to be able to do, and may not even necessarily know where to look if they are seeking to bring in trainers. Whereas with this notion that community partners directly reach out to them and say, like, hey, if you're interested, this is what we can offer. And we would, you can have access to clinicians and talk to them about your questions as to how this works, and maybe help to dispel some of the stigma and the erroneous thinking around these medications. And really approaching this from hey, can we share with you what we know? Might be a great opportunity to establish those relationships and also to sustain those relationships, because that training, can really be done many times over to different staff, new people. Now, this is potentially going to cost some time to already very busy staff that within the community agency, but it's one of these we're sort of thinking about the pros and cons of doing some of these steps would be important for the agency itself.
Those are really great points. Now, I did want to touch on a few practical points related to patient care. You mentioned that even in the incarcerated setting, there is fragmentation of services, and you actually talked about documentation. So psychiatry may be providing some services, but there may be other providers coming into provide opioid use disorder treatment, such as buprenorphine, which may be documenting in a different system. So the jail itself may be a confusing place, and the records may not be easy for outside providers to follow after they're released. Could you comment a little bit on that?
Yeah. So I think certainly this notion of, being able to access records, there might be, 3 different record systems. Most people working in community or hospital settings are going to have a single system where we are able to look at records regardless of, the department or the clinician type, whereas here you might find that there are different systems that don't necessarily talk to each other. And so sort of knowing where the provider of different services is going to be really helpful early on. I think also, one of the things that is important to understand about what's going on inside is that, correctional settings very much function on a hierarchical level. And so, who is the point person to go to for questions? And knowing that as soon as possible, it's going to be helpful. And so, it might be that a particular corrections officer is not providing the information you need, but that could simply be because they don't work on a different unit or might not necessarily have access to the information, and not that they're trying to not share that data with the provider. So, kind of going in with a pretty good understanding of what is the hierarchy, like who are the go-to people, and what are the different groups that are involved in provision of services.
Great. Well, I think this is really helpful, and it really helps to demystify the process for people that are looking to get involved. So I want to thank you for coming on the podcast. Dr. Pivovarva's article, again, is entitled Collaborating with Jails to Provide Community-Based Medication for Opioid Use Disorder, Qualitative Perspectives from MOUD Treatment Providers. Her co-authors were Bianca Planas Garcia, Peter Friedman, Thomas Stopka, Claudia Santelices, and Elizabeth Evans. Thank you for joining us.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.